Okay, I know I don't look like I'm an emergency doc. I feel a bit like a stewardess, but this is not typically what I wear in the ER. Mike, there we go. So these are my disclosures. I have no relevant disclosures. And so in the next 7.5 minutes, I'm going to talk to you about typical ED care to provide context for the patient that's going to be coming to you after they leave the emergency department. I'm going to present some of the outcomes that are associated with your follow-up care after ED discharge. And I'm going to briefly discuss some best practice for these patients. So our research at ICES, which is where I work, we found that in Ontario, there are approximately 20,000 ED visits per year, primarily for heart failure, and a third of these patients will be leaving the emergency department and not being admitted, so coming to you. And of those patients, a quarter of them will be dead a year later. So that statistics obviously brings up follow-up care, and my research is about follow-up care and how much it matters, because I need to know that in order to convince stakeholders to invest more in follow-up care. And when should it happen? And we published this study last year in CMAJ about follow-up care for heart failure patients after they leave the emergency department. And basically, we had 35,000 ED heart failure patients who were discharged, and we looked at follow-up care within 7 days of leaving the ED compared to if they were seen between days 8 and 30. And essentially, we found that everything was better if they were seen within 7 days. So their 90-day mortality was significantly reduced, their 1-year mortality, their hospitalizations within 90 days, and their hospitalizations within a year. So then we said, well, what about if they get seen within 30 days by you? And we still found there was a reduction in mortality at 90 days and 1 year, but we actually found that there was an increase in hospitalizations within 90 days and no benefit anymore. It was lost for 1 year. And that generally suggests, we can't prove it, but it generally suggests that by the time you see them, if it's later than 7 days, things have gotten a bit more unstable and they're probably going to need to be, or more likely to need to be sent back to the hospital. So we've missed a window of opportunity to stabilize these patients. So if you want to help your heart failure patients reduce their mortality, their hospitalizations, when they're leaving the emergency department, we need you to see them within 7 days. And then you might say, well, you send everybody to us from the emergency department. Like, it's common refrain in the ED, follow up with your family doctor. I can say it really fast, follow up with your family doctor. We say it all the time. And I mean, there's a certain number of chronic diseases, but not actually that many. There's COPDers, heart failure, AFib, hypertension patients, maybe cancer patients who have exacerbations and really need follow-up care. And I haven't done the research on all of them, but I have done it on these 3 groups. And I would say if you had these 3 patients, call your office and say, I need a follow-up appointment. I've been seen in the ED. The heart failure patients should be first, AFib next, and hypertension patients last. But of course, they're not calling you. They're calling your medical office assistant. So really, practically speaking, we need to tell the medical office assistants that these are the patients who need to be seen. A quarter of them are going to be dead at a year, and they're the ones who need to be seen first if you only have a few slots to see these patients who are coming from the ED. So what do we do in ED, or what do I do? The usual history and physical. Just to provide context, I ask about shortness of breath, orthopnea and P&D, fatigue and nocturia. I ask about precipitants. If I was working at St. Mike's, I might ask about cocaine. At Sunnybrook, I'll probably ask if someone added yet another medication to this 2-page of medication list, or rejigged your medications. I'll look at their vital signs, primarily their oxygen saturation, as well as their heart rate and their respiratory rate, and listen to their speech. Can they speak a full sentence without getting short of breath? I look at their mucous membranes, their JVP, listen to their lung fields, look for pitting edema, and I use that information to consolidate volume status. If they're well, if their stats are already low, I'm not going to do a walk test. But if their numbers look good already, I will ask my nurse to do a walk test. That means I'm trundling around the ER with a portable monitor and seeing what happens to their heart rate and to their oxygen saturation. I was thinking about weight as I did this talk, because we want you to follow weights. And we typically don't do weights in the ED, but the problem with that is the last time you stood on 2 scales, when did you get the exact same number? So my scale might be slightly different from your scale, which is a problem when you're only looking for a 2-kilogram difference according to the CCS, and even lower in some guidelines. So we don't typically do that, but we should be telling patients they should be taking their own weight when they go home so that they can bring that into you and you can follow that. We do the usual investigations. Troponins, obviously, I'm trying to rule out causes of CHF like AMI, so I'm going to look at their tropes. I'm going to do a chest x-ray. Maybe they have pneumonia, and that's pushed them over the edge. Maybe that's why their heart failure has gotten worse or come on for the first time. And then ECG, I want to look not just for signs of heart failure, but also for AFib. Maybe they've been ticking along at 150 for 2 weeks, and that's like running a marathon for 2 weeks for their heart, and no wonder they've gone into heart failure. We do BNP occasionally. Typically, if we're trying to figure out, many of these patients have multimorbidity, so they often have COPD along with their heart failure, and if we can't figure out the cause of their dyspnea, we do a BNP. The other time we do a BNP is if they're being admitted, because there's been studies that show that if you follow the BNP through the admission and see that it's coming down, that relates to prognosis, and it tells you how you're doing. Is it getting better, or is the treatment not helping? We don't do that in the outpatient community setting, but I'm thinking it probably works, just no one's done that study, and maybe that's a new study for me to look at. So treatment, if they're very sick, obviously I'm calling for BiPAP, thinking about intubation, and nitro. But most of the time, I'm giving these patients furosemide, and I usually do it PO because it's cheaper for the hospital. And I'll just double whatever their usual dose is, or start low if they're not on it at all. And I give them some time. I walk away, go see some other patients for a couple hours. And then I come back and see if they diurese, and if they have, then we do the walk test. And if you look at the CCS guidelines, we're allowed to send home if their SATs are less than 92. I'm not comfortable with that, and I think most of the emerge docs are not comfortable with that. If you're above 94, okay. If you're below that on your walk test and you're tachycardic, 1-800-MEDICINE, come on down. So that's how we mostly think. And then when I discharge these patients, if they pass the walk test, I say follow up with your family doctor in a few days. We all say it. And then we hope. We hope that they're motivated enough to call. If they call between 12 and 1, they call back. If they call after 5 o'clock that they don't get if this is emergency, go back to the ER. And that they're going to be able to tell the medical office assistant, I have heart failure. Because I think we're all a little afraid to tell patients you have heart failure. If you think about it, it's a really scary thing to hear. Your heart is failing. And I feel like we don't tell them very clearly that's what the problem is. So often we will just refer these patients to a clinic that we have in our hospital, which I have one at Sunnybrook. The problem with that is if they already have a cardiologist and they have you, now they're going to another doctor to jiggle with their meds. It promotes poor continuity of care. And the other thing is, if you're at Markham Stouffville, maybe they don't have that clinic. And it promotes a patchwork solution across the province. We want everyone to have good access to care, particularly these patients. So what do I want from you when you see them? The same thing, history, physical, take their weight. Should you do a BNP? If we didn't do a BNP, it's probably not going to help you to do a BNP. You can get them. I checked with a few of you that, they take a day or two to come back. But if we did a BNP, and you can see it on Connecting Ontario, you have one of those offices, can see what we did in terms of our labs, then you could certainly repeat it and see if it's going up, and that's not good. And maybe they need to go back to the ER to see me again, and I'll try again. Or maybe if it's going down, great. In general, what I want you to do is just to adjust that furosemide dose. If I sent someone on Lasix, it's hard on their kidneys. I don't know if they're going to be seen by someone. I want you to just reassess them, listen to their lungs, and adjust the dose to make sure that it's the lowest effective dose, because that's typically all we do in the ER. And of course, what's most important is you optimize the guideline medical therapy, this is the triple therapy. That didn't work out so well. And then, of course, you've probably heard of the new meds. We are starting to see patients on these meds and getting a little bit nervous about them. We don't typically start them in the emerge, and I'm not sure if any of you do. They're only for patients with reduced ejection fraction. The CCS has some great little guidelines and things online that you can look at. I pulled this from their bridging guidelines to your practice, and it basically just tells you how to start these medications. But like the combination one requires a 36-hour washout period. It's not that simple. You have to think about bradycardia and hypotension. You can't start on these patients, but maybe send them to someone who can. And then there's also those little booklets. I keep them in my lab coat when I'm in the ER to pull out to make sure I can't keep on top of everything. And this is mostly my research area, and I still need help with this. So having these little pocket books is great. And I'm going to hand over to Doug now.
Okay, so I'm going to talk about what happens. That was a great talk on what happens to your patient when they go to the emergency department. I'm going to talk about what you can do in your office and primary care physician or a community physician, community cardiologist, to try to reduce the ED visits for potential heart failure patients by diagnosing them earlier. Can you hear me okay? There's a bit of an echo, I'm not sure. Is it okay? So the second part of it, I think we're going to talk very briefly about coronary disease and that intersection with heart failure and how it's related to preventing that first episode. So the heart failure is a costly disease. This slide shows the costs per heart failure patient in different countries and the costs of healthcare per capita. As you can see here, the costs of heart failure is about 2 to 3 times that of the per capita costs. Very expensive in the United States and Germany. And Canada is somewhere in between, but still about twice as expensive for a heart failure patient as it is for those in the general population. And what drives these costs? Well, it's the costs are directly related to hospitalizations. And if you look at these countries and break them down into the costs of heart failure and the proportion of the costs that are due to hospitalization, you can see that there's a linear correlation between that. So if our heart failure patients are ending up in hospital, and it's really driven by the nursing, by the room and board, by expensive procedures like dialysis. If our heart failure patients are ending up in hospital, that's really adding to the substantial costs that are going into managing the heart failure patient from an economic standpoint. And when they end up going to the emergency department to see Dr. Atzema and her colleagues, what we'd like to do is to try to prevent that from happening by potentially diagnosing heart failure patients earlier so that they can get treated, started on diuretics in the office, and perhaps not end up in the emergency department. Now, the Canadian Cardiovascular Society guidelines suggest this kind of flow chart for diagnosis. And the guidelines are, they're updated regularly and very important. But you know that it's difficult to diagnose heart failure patients in the office. They have insidious symptoms. Often they have shortness of breath. Everyone gets short of breath. It's hard to tell whether this patient actually has heart failure or not. And so the physical exam also adds to this, but sometimes can be a little bit misleading. But still, this is the cornerstone: the clinical history and the physical exam. And when you suspect heart failure after the history and physical exam, the next thing to do is to assess their natriuretic peptides and to get an echocardiogram. Can we improve upon how we diagnose heart failure patients in the office, clinically, in primary care? Well, there are actually studies that have been done to try to use diagnostic algorithms to improve the diagnosis of heart failure. The two on the left by Rolfe and Fahey are published in the primary care setting. Looking at primarily whether they had a previous myocardial infarction. There's some physical exam features, leg edema. And then on the right, in patients who are referred for echocardiography or patients with diabetes in primary care, you can see that there are many things that you can potentially look at to facilitate an earlier diagnosis. These studies actually showed that the models actually performed quite well in the original studies. So C statistics were 0.85 to 0.9 in some cases, 1 being a perfect test, 0.5 being like a flip of a coin. And so these are actually pretty good. But the true test of any predictive algorithm or decision tool is how well it validates in a different population. And this study there was a recent publication in ESC Heart Failure testing these 4 tools and found that it didn't predict as well when you tested them in a different cohort. The C statistics were about 0.65, and the sensitivity and specificity was poor. Now, this group did also test the performance of brain natriuretic peptide. And BNP, in contrast, to the physical exam had the best discrimination. The area under the curve was 0.85 and had a high sensitivity and specificity of around 80%. And so BNP still is coming through as an important diagnostic measure, even in a primary care setting. Another biomarker that you're going to potentially see a little bit more often now is the high sensitivity troponin. And this is a study of British men, middle-aged men, 40 to 59 years old, in primary care. And they had a high sensitivity troponin done. And you can see that the troponin level in the office actually predicted whether they're going to have heart failure. Whether the patient had coronary disease on the right or was free from coronary disease. Elevated high sensitivity troponin was a major predictor of future heart failure risk. And so this is another potential biomarker as well. And just kind of continuing on with this, the discussion about coronary disease, we saw that a prior MI was one of those common risk factors for heart failure. We saw the troponin. And this study done in France was a registry of over 4,000 outpatients with stable coronary disease who had a baseline ejection fraction. And the major predictor of whether they were going to develop heart failure in the future was their EF at baseline. An EF less than 50%, even slightly less than normal, was a major predictor of heart failure, as shown by the top line. The EF did not predict whether they're going to have a future heart attack, but was a strong predictor of heart failure if it was slightly reduced. So if you have an ejection fraction on a patient of 48%, that's still something that you need to potentially be concerned about. I'd like to kind of, this is just before closing, show this slide. And this is from the Canadian Cardiovascular Society guidelines for people who have diagnosed heart failure. So once they have heart failure, what do you do? How do you manage the patients? Essentially, the bottom line here is that unless the patient has no symptoms of chest pain, is not a candidate for coronary bypass, not a candidate for PCI, which is the right side over here, basically everyone should have an evaluation for coronary artery disease, either invasively or non-invasively, to see if there's a reversible cause. And so I think this is true for established heart failure, but I think as you see patients in your practice, in primary care or in the office, as a cardiologist in the office, be with someone with coronary disease in front of you, one really needs to be cognizant of the risk of developing heart failure in that group, potentially by doing earlier biomarker testing and assessing for ischemia as well as their LV function. In closing, I'd like to conclude by we've shown you that the economic burden of heart failure is high. It really correlates with high rates of hospitalization. And there's some of the strategies, we need strategies to try to improve earlier diagnosis of heart failure, and this will potentially reduce the visits to the emergency department. It could be improved with BNP and high sensitivity troponin, the coronary disease is an early important antecedent for heart failure prevention. And before I close, I know you're all thinking, how do I get BNP and troponin on my patients in the office? We do them at the hospital. And I think patients with a connection to the hospital, who are definitely those who are being co-managed by a cardiologist, or those who have had a connection with the hospital, can certainly still get their BNP testing done at the hospital. There are point-of-care tests. I think we, as a community, need to kind of move the needle forward. Need to move the needle a little bit to earlier usage of BNP, perhaps in selected cases, not in everybody, but in selected cases where there are higher risk of heart failure. Thank you very much.